We put this together in a collaboration between the ASEAN Secretariat, the T-20, University of Indonesia Stop TB Partnership, and USAID. We're honored to have a series of distinguished guests. And I will turn this over for the first welcoming remarks from Dr. Hasdullah Tabrani. He's the lead co-chair of Global Health Security and COVID-19 Task Force for the T-20 Indonesia, as well as the Indonesian Chief of Party for Think Well. Previously, Dr. Tabrani was a professor and former dean of University of Indonesia School of Public Health. Back to you, Dr. Tabrani, and thank you for joining us.
Thank you, Professor Kenneth. Good morning, good afternoon, good evening, everyone who are joining from different part of the world. First, I would like to thank the USAID and our team at the Faculty of Public Health, Universitas Indonesia, that organized this webinar. This is a serial webinar organized by T-20, it's independent think tank organization that provide recommendation and try to find a best way to recommend to the G20, especially here in Indonesia, where the Indonesia is now serving as the presidency of G20 of 2022. We already have various webinar, focus group discussion, roundtable discussion to develop policy brief of various aspects. Preferably, we already identified 10 policy areas that need to be submitted to the G20 next month to the president of Jokowi as the president of G20. Covering various issues on universal health coverage, diagnostics, airborne disease like today, and the day after tomorrow, we will have also diagnostic and early warning system discussion. We have done webinar on One Health Tool together with USAID. We already organized universal health coverage funding system, also with support with USAID. And also we still have various webinar. It's coming to get the information, ideas, new innovation to restructure the health resilience of the world after COVID-19. We learned a lot that airborne disease, human-to-human contact, pandemic of COVID-19 has brought all attention from all over the world, and we have been understanding better on the correlation between health and economics, and now most of the leaders of the world all talking health sector because the impact of the pandemic to health is very, very big. Consisting or affecting almost all countries in the world, large or small, low or middle income or high income. These externalities of the infectious disease are overwhelmed, that we have to prepare for other possible, although we don't want it, we don't expect it, but other possible disease, especially airborne disease that can spread quickly across countries, across regions, across the globe. Hopefully, our colleagues here who are attending this webinar can generate innovation that will contribute to the improvement of health resilience, preparedness of pandemic once it may be happening. We have to strengthen our capacity in diagnostic and sharing the information, data sharing, also early warning system across countries, and sharing financing, establishing good financing to ensure equitable financing in the vaccines and treatment. Thank you for everyone. Thank you for our colleague USAID. Thanks for the moderating this evening. Please enjoy the discussion. Thank you.
Thank you, Dr. Tabrani, for your welcoming remarks. I would like to now call upon Professor Mundastri Sudaryo, who's a physician and epidemiologist serving as Dean of Faculty in the School of Public Health at Universitas of Indonesia. Professor Sudaryo is also the chairman of the university's Health Research Center for Crisis and Disaster. Over to you, Professor Sudaryo.
Thank you very much, Professor Kenneth. Within Indonesian time zone right now, allow me to greet good afternoon, ladies and gentlemen, and maybe good evening in other parts of the world. Dear distinguished professors, experts, government officials, and eminent participants of this webinar, allow me to extend cordially welcome to our honorable keynote speakers as follows. First, His Excellency Dr. Matume Joseph Pala, Minister of Health, South Africa. Second, Professor Kenneth G. Castro, distinguished professors from Emory University in the field of global health, epidemiology, and infectious diseases. The third, Professor Hasbullah Tabrani, distinguished professor from Universitas Indonesia, as well as the lead co-chair Global Health Security and COVID-19 Task Force T-20 Indonesia. I also would like to warmly welcome all honorable international speakers, including the moderator, who will be giving presentation in all 4 sessions within these 2 days, to whom I apologize for not mentioning the names one by one. It is really a great honor for us having all of highly respected resource person and participants in this 2-day webinar entitled Airborne Infectious Disease Defense Platform, abbreviated as AIDP, introductory webinar. As just mentioned by Professor Tabrani, and as everybody here might have known, that this webinar is a T-20 Task Force 6, particularly supported together in collaboration by USAID, Stop TB Partnership, and CHAMS, one of our research center in Faculty of Public Health, Universitas Indonesia. We would like to express our high appreciation to USAID and Stop TB Partnership for this important and strategic collaboration. As being supported by USAID, together by the Stop TB Partnership, WHO, and other key holders, the Airborne Infection Disease Defense Platform has been developed to support programs that advance early detection and community response for COVID-19, TB, and other airborne diseases across Southeast Asia. I suppose that in this webinar, experienced and well-known international experts will share and exchange their knowledge and thoughts about Airborne Infection Disease Defense Platform, the urgent realities of TB and COVID-19, and other airborne threats nowadays and in the future. And also, of course, the lesson learned from high TB burden countries, including Indonesia. We wish all of us enjoy the fruitful scientific discussion and get better insight from the enlightening knowledge sharing. Have a good day, sir, professors, colleagues. God bless us, and again, thank you very much.
Thank you, Professor Sudaryo. It is my honor to next introduce to you His Excellency Dr. Matume Joseph Pala. He is the Minister of Health for South Africa. His Excellency Dr. Pala is also a board member of the Stop TB Partnership we're particularly grateful because I'm aware that he traveled recently back from Montreal, where he was participating in the International AIDS Society conference. Over to you, His Excellency, Dr. Fala.
Thank you very much. Thank you very much, moderator, Dr. Kenneth Castro. Thank you for the invitation. I'm trying to just get my camera in a better position. I hope I can be seen. Thank you very much. Thanks to the previous speaker, Dr. Hasbullah Tabrani, the lead co-chair of Global Health Security. And thanks to other participants in this very important webinar. Let me start by thanking the USAID and the Stop TB Partnership on behalf of Think Tank T20 for inviting me to speak at this event, focusing on the Airborne Infection Defense Platform, AIDP, as already indicated, as a G20 introductory webinar. I also participated last year on the 28th September where I spoke about TB at the Center of Airborne Pandemic Preparedness and Response during the 34th meeting of the board of the Stop TB Partnership. I've been informed that this Think Tank T20 event will introduce the AIDP to the G20 Global Health for the pandemic preparedness, and also the Global Health Security and COVID-19 Task Force. The topic of this webinar is very closely related to last year's topic. So a second invite to us shows that you believe that South Africa is still very relevant in these very important matters which this webinar will be dealing with. As you know, that's easy to understand because South Africa is among the 30 highest burdened in terms of tuberculosis, constituting about 3.3% of the global TB burden. And that therefore explains why this webinar is critical for us. And that is also the reason why when we were asked to come and share some thoughts in opening this webinar, we didn't find it difficult, notwithstanding, as the moderator indicated, I just landed late last night from the International AIDS Society conference in Montreal, Canada. But it was not a difficult matter to agree to participate in this webinar. Now, COVID-19 has exposed the old weaknesses of our health systems. While the pandemic has brought several challenges, we have also seen opportunities as well through the lessons learned on the actions we were able to take against COVID-19, and we're still taking, because COVID-19 pandemic is not yet over. It might be less of at the highest level like it was over the last 2 years, but it is still in our midst. A lot of people are still infected and some are still dying from this. This engagement is critical for us at the moment that we are gathering our thoughts to compile our national strategic plan for HIV, TB, and sexually transmitted infections. This plan is very important in that this particular national strategic plan will cover our operations from 2023 to 2028, which is a very important period because it's a period very close to 2030, a year by which the United Nations high-level meeting has made commitments for stopping HIV and AIDS, but also TB as a world health threat. So the strategic plan which we are working on is to take us through to 2030 because its term will end just 2 years before 2030. The recent unveiling of the Airborne Infection Defense Platform by President Biden is a step in the right direction. We have noted that US aid will provide $10 million to the AIDP to support programs that advance early detection and community response for COVID-19, for TB, and also other airborne respiratory diseases across Southeast Asia. I believe this is an initial phase as per the declaration made during the May 2020 US and Asian Special Summit at the White House in Washington. The AIDP is a program that is required globally. In our journey to end tuberculosis, we need to ensure early detection, rapid linkage to care, to treat, because treating successfully, if we can, because TB can be cured. When we're able to treat TB successfully, we also contribute towards prevention of any further spread. But we must also, once we have initiated people on treatment, we must be able to retain them on treatment and care. Currently, we are mainly using molecular tests such as the Gene Expert for detection of TB and various conditions, including COVID-19. This technology is effective, although there is need for more novel tools. In South Africa, our TB prevalence survey has indicated that there are a high number of people with asymptomatic TB. These people remain undiagnosed and they transmit TB in their communities. This is the reason why we need more tools, such as the digital chest X-ray and other rapid molecular tests. Political commitment is required in every country if we are to get these new tools so that they can help us to diagnose and put people on treatment. We need to capitalize on the fact that COVID-19 pandemic has assisted in the prioritization of infection control practices in our health facilities with screening and testing for eligible patients. And this is conducted on entry into the health facilities, but also the universal use of face masks and also social distancing. These are very important methods, not only in containing COVID-19, but all especially respiratory infections, airborne respiratory infections. Something that the TB programs has tried to do. These are interventions which the TB programs have been trying for many years, but we are happy that at least, with the advent of COVID, these methods are now quite entrenched. Now that the use of face masks is no longer compulsory in many countries, efforts must be made to maintain the practice in the healthcare facilities, particularly in the areas of high burden of TB. In our countries which are highly burdened with TB, we must maintain some of these infection control measures, even as we are no more at the height of COVID-19. Such a measure will go a long way to prevent other airborne diseases. What we need to do is to ensure rapid adoption of new tools that will assist us with the detection of TB and other airborne diseases, because history has shown that when part of the world is left behind, we may not get the global success that we are desiring to achieve. To put in place a parallel process, we must also put in place parallel process of research and implementation. We must put in place a process of learning and implementation in some instances. It is very harmful to delay access to innovation under the excuse that it is still being perfected. So as we research those methods which we find that are quite helpful, we must immediately put them into implementation and not wait for them to be perfect. We must ensure communities have access to the new tools as soon as they have been proven to be effective. We must foster strong partnerships and collaboration in order to ensure that there is sufficient technical capacity to manage these innovations. We must put in place an online surveillance system, which includes the private sector with all the data, including that from private sector, as we did in the case of COVID. So also for other airborne diseases like tuberculosis, not only the governments and public sector, but also the private sector must come on board. All these interventions require additional financial and human resources. We therefore need to mobilize funding required for implementation. So we must give support to the Global Fund in its endeavor to raise $80 billion US. Lastly, I would like to state that experience from COVID-19 has shown that where preparedness guidelines and plans for epidemic-prone diseases are in place and are adequately implemented, not only are outbreaks detected timelessly, but the response has proven to be rapid and well-targeted, resulting in effective controls. Therefore, we must ensure that we have integrated plans for epidemic and pandemic preparedness and responses with response teams at different levels of the outbreak system, which can be activated quickly in case of an epidemic or a pandemic. It is against this background that we support the initiative of the AIDP, and I hope that other countries will find this very useful, and we are looking forward to see this initiative being launched and implemented globally. I wish this webinar all the success, and we're looking forward to some of the recommendations which will come as a result of this webinar. Thank you very much to the moderator.
Thank you, Minister Fala, for your words. And I would like to also thank Drs. Tabrani, Professor Sudario for their welcoming remarks. With this, we conclude the opening session of this webinar and move to the first session entitled TB Policies, Platforms, and Political Commitment as the Foundation for an Airborne Infection Defense Platform. Please be aware that this is being live streamed and recorded, and we invite participants to put any questions you might have or comments in the chat section. We will attempt our best to respond to these on a real-time basis, or else we will follow up with you following the conclusion of the webinar. It is my distinct pleasure to introduce to you our next presenter, who's a personal friend and colleague, Dr. Suvanand Sahu. Dr. Sahu is a physician and the Deputy Executive Director of this Partnership Secretariat. He's trained as a public health specialist and has over 20 years of experience in tuberculosis. And Dr. Sahu is going to talk about TB, global health security, and the Airborne Infection Defense Platform. Over to you, Dr. Sahu, and thank you.
Thank you, Ken. If my slides can be put up at this stage. Thank you. Honorable Minister of Health of South Africa, distinguished participants, ladies and gentlemen. Greetings from Stop TB Partnership. In the next few minutes, I will talk on TB, global health security, and Airborne Infection Defense Platform, or AIDP, how they are all connected and why we should invest on defending from airborne infections. Next slide, please. On the top of this slide, you see a list of diseases: TB, smallpox, measles, pneumonic plague, influenza, SARS, MERS, COVID-19. Besides being bad diseases, do you see anything common amongst them? Yes, there are commonalities. All have an airborne or droplet mode of transmission. They spread easily between people, and they are responsible for many deaths. Next slide, please. Airborne diseases, next slide, please. Airborne diseases are the biggest health security threats. We knew it before COVID-19, but we now for certain know after what we have seen during the pandemic of COVID-19. Airborne and droplet infections can spread like no other routes of transmission. Large numbers of people get infected, and all people are at risk because air and breath is life. So everybody is exposed to this risk. They can cause serious respiratory illness or escape immunity or become resistant to medicines. Now let us look at TB and COVID, the two most relevant airborne infections in the context of the health security threats. First, in TB, one person can infect 15 others per year if untreated. Nearly 2 billion people are already infected. It is a deadly disease with 15% mortality. The mortality could be higher if untreated. So, and drug-resistant variants are an issue in antimicrobial resistance. They are difficult to treat and even come with a higher mortality. Next, in COVID-19, one person can similarly infect many within days. So far, 572 million infected in 2.5 years. It is deadly with 3.5% mortality. The percentage seems lower than TB, but in terms of the large numbers of infection, the total deaths is higher. And variants can also emerge here and become more transmissible or escape immunity. Next slide, please. We need to defend against airborne infections for global health security, as well as for pandemic preparedness. On this slide, I present 3 reasons why the world needs to invest on defending against airborne infections. First, COVID-19 pandemic was a wake-up call. It underscored global unmet needs in addressing airborne infectious killers. We saw how the world was completely unprepared to fight airborne infection. Air defense systems of mighty armies could not stop an airborne virus. Existing hospital infection prevention and control practices, IPC, could not stop airborne bugs because those practices traditionally were focused only on parenteral transmission and not airborne transmission. Second reason, the next pandemic, especially if we are talking about a pandemic as devastating as COVID-19, is very likely to be an airborne disease. The third reason is the fact that TB, an airborne disease, is an ongoing epidemic. Some have also called it as a pandemic, which has a sustainable development goal target to end it by 2030. As we will see in the subsequent slides, responses to TB are similar to what is needed for other airborne infections. Next slide, please. Now let us rewind back to 2020. Much has been talked about the impact of COVID-19 pandemic on TB. Let me highlight 2 points here. First, I want to highlight the fact that in many high TB burden countries, TB programs were launch pads for COVID-19 responses. It was an obvious choice to look towards TB when confronted with a new respiratory killer infection. TB programs had the expertise on testing, contact tracing, respiratory care, masking, ventilation, even ultraviolet lights, etc. TB programs, human resources, equipment, and infrastructure were quickly repurposed to include COVID-19. this was a good contribution of TB programs to the COVID-19 pandemic. However, the second point I wanted to make is what went wrong and why. There was a huge setback to TB services. Service delivery and access to TB diagnosis and treatment declined, leading to an 18% overall drop in 2020, reversing a good trend in previous years, as you can see in the graph on the slide there. The reasons could be multiple, but one common and clear reason was that historically TB programs were underfunded, overstretched, and did not have the surge capacity to deal with both TB and also a new infection like COVID. If TB programs were well funded with good surge capacity, then they would have contributed more to the COVID response, and TB services would not have been disrupted at the same time. Next slide. Inclusion of TB in pandemic preparedness and response is one of the ways to increase funding for TB, funding that could serve the dual purpose of fighting TB as well as getting prepared for future pandemics. Let me talk about why TB needs to be the centerpiece of airborne infection defense approach and integrated into future PPR initiatives. TB is an airborne disease present in almost all countries and very likely to outlive the COVID-19 pandemic. It is a disease that will stay in between pandemics and will continue to test how prepared we are for fighting an airborne respiratory infection. Adding investments to strengthen infrastructure and capacity of TB programs will help in developing surge capacity to fight new airborne infections. In between pandemics, monitoring progress in TB could serve as a marker of the state of preparedness to fight new airborne infections. So integrating TB into PPR is a smart way of investing on TB and preparing for future pandemics. Many people have also mentioned that PPR should include new as well as old infectious diseases, and TB fits very well in this context as an old infectious disease which has claimed more lives than any other. To take concrete steps towards integrating TB into PPR, we suggest an airborne infection defense approach. Can you go to the next slide, please? Here, I had said earlier that TB responses are similar to responses you would plan for other airborne diseases. So let me list a few of them, which are dual purpose tools and interventions used in TB. Modern ultra-portable X-ray systems that can now read the X-rays through artificial intelligence. The Honorable Minister also mentioned about X-ray in South Africa context. Also the rapid molecular diagnostic platforms that the Minister mentioned. Contact investigation has been used in TB, but it is also a useful tool against any infections. Genome sequencing that we saw in COVID-19, it has also used in drug-resistant TB detection. Community-based or community-led work in TB on screening, referral, care, monitoring, promoting rights, gender equality, and stigma reduction can help the fight against other airborne infections as well. Airborne IPC has been implemented in TB services for decades. Now it's time to scale it up across the health system and even in congregate indoor settings. And specialized respiratory care can also have dual purpose of TB and other respiratory illnesses. Next slide, please. Now, coming to the proposed airborne infection defense approach and platforms for this to happen. Here is the objective. Here the objective is to develop capacity of high TB burden countries to defend against deadly airborne or respiratory infections. It needs to be built on the experience and expertise of country TB responses. High TB burden countries have years of experience on this, so there is no need to reinvent the wheel. What is specifically needed is to establish AIDP in countries and network them for learning and sharing lessons. Next slide, please. This is how an AIDP platform would look like. It will have components on screening and diagnosis using new technology and dual purpose diagnostics, community empowerment and engagement, contact investigation capacity enhancement, community-based decentralized systems for care, surveillance, and rapid response, airborne infection prevention and control. And overall, it will require the political commitment, coordination with all stakeholders, TB as well as other airborne infection stakeholders, and use of TB knowledge, policies, expertise, and should be able to learn and share experiences. Next slide, please. I would end by reminding the audience that recently Stop TB Partnership released a new global plan to end TB, 2023 to 2030, and there is a section on TB and PPR, which I encourage you to read. Thank you for the time and attention. I hand over back to Ken.
Thank you, Dr. Suvanand, very much for this excellent presentation. Without further ado, it is my distinct pleasure to introduce to you our next presenter, Ambassador Mark Dybul, Professor of Medicine at Georgetown University Medical Center. Dr. Dybul is a physician and professor in the Department of Medicine at Georgetown University, and he previously served as the executive director of the Global Fund and was former PEPFAR Global AIDS Administrator. Dr. Dybul is going to talk about TB platforms and preparations for airborne pandemics. Over to you, Mark, and thank you for being with us.
Thanks, Ken, and thanks to USAID, Stop TB, and the other sponsors of this, in particular, Indonesia, for keeping something as important as pandemics on the G20 schedule for this T-20. You know, I've spoken a lot about pandemics recently, in part because I was a member of IPPR and in part because I spent my life with pandemics. People say I sound angry. I'm not angry, I'm just really fired up. And I'm fired up because we are 2 years into the most devastating pandemic in terms of destruction of economies, global impact that we've ever seen. And we are at least no better than, and possibly worse off than we were 2 years ago. That is unforgivable and a massive failure of policy, and a massive failure of political leadership, and a massive failure of global leadership. And why I'm fired up is everyone keeps telling me, oh, the IPPR recommendations, the G20 recommendations, they're too difficult. We don't have the power, we don't have the ability to create political structures, policy structures, response structures in a global way. Absolute garbage. Absolute garbage. We did this 20 years ago. The Global Fund was created, PEPFAR was created, Gavi was created. We know how to do this, we can do this. All these things are just excuses. What we need is leadership and we need leadership in new places, like from Indonesia and South Africa and other parts of the world. We can't rely on the old structures because the world's completely changed. And it can't just be the G20 because there are a lot of countries that are in the G20. And I would also point to great successes. Africa as a region in COVID had by far the best response, led by John Kengasong under the leadership of His Excellency President Ramaphosa, who is still champion for COVID for the entire continent. The heads of state met regularly as a bureau. They created structures, they had response. What they lacked was support from the rest of the world. South Africa fielded 25,000 community healthcare workers who were there for maternal child health and TB and HIV, and went out and could have actually contained their first wave, but no one supported them with diagnostics or vaccines or therapeutics or oxygen for that matter. So they couldn't do anything. So the notion that we can't do anything, we can't act, is absolute nonsense. What we have is a failure of policy and political leadership, and now is the time to overcome that. All it takes is a small number of heads of state. You get the heads of state and government from Indonesia, from South Africa, from India, from the United States, a European country. This is done. We just need to do it and do it now. And I also, going into tuberculosis and the platform, Sahu's already done a really good job. I just want to build on a couple of points and add some things he didn't add. One, case identification is hugely important, not only for current pandemics, but for future pandemics. TB has actually done a tremendous job finding people in difficult places. Most pandemics don't start in easy places. You need an infrastructure which TB and maternal and child health and many other HIV, malaria have programs to do. We just need to intentionally build off of them. And while I totally agree, TB is a platform that should be used, it can't only be TB. In some countries, TB isn't the main disease. Certainly in Asia, Southeast Asia, and Africa, TB is a great platform. It's not going to work particularly well in Europe. And we need something that's a global response, and we should do country by country, region by region. But in much of the world, TB is a great platform because it has a strong infrastructure that Sahu talked about, and I won't go into, just to emphasize the community outreach piece, which is so important for identifying new pandemics and also responding to them to make sure people stay on their therapeutics, are identified, get vaccines when they need them. Stop TB in particular has funded programs or supported programs that are funded by others that have identified such people. I also want to point out, and this is something that is one of my pet peeves, identification has not been the problem. We identified COVID as a massive global risk in December and January of 1919 and 2020, and we did absolutely nothing. The IPPR talks about the lost months of February. Monkeypox, we knew was coming, and we still have an endemic. We've known about TB for millennia. We've known about HIV for 30 years. Knowing something is coming does not solve the problem. Now, I do believe we need global surveillance systems, and most importantly, we need links between the zoonotic world and the human world to identify pandemic threats, which isn't that difficult. So we absolutely need to do that. But the problem has not been identification. We've identified all of these things long in advance and completely failed in our response. So building the response, yes, we need identification, but the failure has not been identification. The failure has been response. I pointed out the community piece, but I also want to focus a little bit on end-to-end research and discovery, where I think tuberculosis has a lot to offer. And what's important here is that the end-to-end research and discovery and delivery through production and delivery has to include discovery in low and middle income countries or in the G20 and beyond. If you don't control discovery, you will never have access, as COVID has taught us again and again. Tuberculosis with Johnson & Johnson, Eli Lilly, some actual local companies, you can do joint discovery for new products for tuberculosis that would respiratory diagnostics, vaccines, and treatments that could then be a respiratory platform that you could plug and play for the next threat, pandemic threat. But they need to include discovery in countries, in local countries. And South Africa and many other countries are starting biotech parks, but their biotech parks are being controlled by producers. We need actually discovery to be built in these countries as well. And then end to end, from discovery to research and development to clinical trials. There's a great low and middle income country trials network called Together Trial that I'm associated with that was started for COVID, tested 12 products in the time it took most big companies to the time it took them to fail with one therapeutic. Together Trial tested 12. It's now an international network that spans the world through research and development, through clinical trials, then through production. And the production capacity is important, but it can't just be for RNA, although that could work for TB, which gets back to the discovery. And discovery has to be linked to the production so that it's not just discovery in high-income countries producing in low-income countries and then limiting what low-income countries can do, lower-income countries, low-middle-income countries can do, but building that end-to-end. And then also having production for the rest of the world, not just contained to the region that the producers from high income countries tell you can produce for. And then distribution, and the distribution networks, including the communities, the diagnostics in the communities. TB has that end-to-end platform that's being built that could be expanded for tuberculosis, but then also for surge capacity for respiratory diagnostics, vaccines, therapeutics, for the future, and that platform for future pandemic threats. And the fastest pandemic threats will absolutely be respiratory, as Sahu mentioned. So there's going to be a whole lot of discussion about a lot of other things, but I wanted to emphasize the community piece because the community piece is something TB has done well, reaching the vulnerable. And if you don't reach the vulnerable, if you're not monitoring the vulnerable, you will not pick up the next threat and you will not be able to respond to the next threat. But that end-to-end R&D, that platform that needs to be built, that TB actually has in some ways more extensive of a platform and more relevant of a platform for the next pandemic threat from a respiratory pandemic than nearly anything. So I'm going to run out of time and I don't want to take more time than I need. I want to end where I began. We are more than 2 years into a devastating pandemic that has shut down the world. I am so tired of these conversations over and over and over again. We can't set up the political structures. We can't set up, it's too complicated. Let's organize a treaty. Fine, let's do a treaty. We have too many players. All the same stuff we heard 22 years ago when the Global Fund was created, when PEPFAR was created, when Gavi was created, and now we have examples like the African response to COVID. That was a perfect political and policy response. They just didn't get the support they needed. This is possible. So let's stop complaining. Let's stop whining. Let's actually do, because we've done it before, and let's act now. And if countries like Indonesia and South Africa and a few others step up, this can be done. And TB is a great platform. And if we build platforms to fight current pandemics, we will maintain those platforms for everything, including the R&D end-to-end for the next pandemic. So let's stop talking and let's act. Thank you.
Thank you, Dr. Deibel. Very much appreciate your clarion call. It's time for action. I could not agree with you anymore. Let me now invite our next presenter, Dr. Supafon Saditan, who is the Deputy Permanent Secretary, Ministry of Health, Laos People's Democratic Republic. Dr. Saditan was Director of the International Relations Division of the Cabinet of the Ministry of Health and focal point of ASEAN Senior Official Member Health Department. He will talk about the importance of pandemic preparedness and tuberculosis in the ASEAN region. Over to you, Dr. Saditan, and thank you for joining us.
Your Excellency Chair, distinguished delegates, ladies and gentlemen, a pleasant day and evening to all of you. As the current chair of the ASEAN Samhesti, appreciation is extended our participation this timely G20 introductory webinar. We do take note that the Airborne Infection Disease Defense Platform, or AIDP, as chaired in the ASEAN-US Special Summit in May 2022, will support programs that advance earlier detection and community response for COVID-19, TB, and all the airborne disease across the region. Next slide, please. The next slide, please. The strategic importance of such a platform is similar to the strategic value of the various platform and mechanism of the coordination and collaboration in the realization of the vision of the ASEAN post-2015 Health Development Agenda for 2021 to 2025, which is healthy, caring, and sustainable ASEAN community. This was adopted by the ASEAN Health Minister in May 2022. This APA is currently being implemented through the ASEAN Health Cluster Work Programs, with regional activity support to the operationalization of the 21 health priorities and show in the slide. Relevant to the expectation of the AIDPs and ASEAN Health Cluster 2s and on responding to the on-hazard emerging threats and regional activities that address the gap and need relevant to the pandemic response and to TB initiative. These regional activities are particularly under the health priority 8 and on prevent and control communicable and emerging infectious disease and health priority 9 on regional preparedness and response. Next slide, please. These two health priorities have always been part of the major initiative of the ASEAN health sector since the first collaboration meeting of this health minister in July 1980. In the current APRA, the key target including among other those for reduction of the tuberculosis incidence rate, coordination and cross-sectoral engagement, operationalization of the ASEAN Center for Public Health Emergency and Emerging Disease, and the ASEAN Public Health Emergency Coordination System, and also the post-pandemic recovery initiative on the enhancing health system under the ASEAN Comprehensive Recovery Framework. Next slide, please. Related to the regional initiative public health emergency, including the pandemic response, such as this ongoing COVID-19, and the ASEAN health sector has scaled up and sustained activities on the networking of the Emergency Operations Center, this disease and laboratory surveillance, managed program on the big data analysis, and virtualization of risk assessment and ensure vaccine and drug security and surveillance. They will show in the first column. In additional, there are health-related guidelines and protocols that have been adopted by the ASEAN Health Minister to support the graduate opening up of the economy wide at the same time sustaining public health and social measures to future limit transmission. These are shown in the second and the third column. Next slide, please. As mentioned under the previous slide, the health sector is currently setting up the UpFeed and the Center Excellence and Regional Resource Hub to strengthen the ASEAN region capability to prepare for prevention, detection, and respond to the public health emergencies and emerging disease. Next slide, please. With regard to the TB initiative, it is one of the communicable disease to be addressed by the APA, especially under the responsibility of the ASEAN Health Cluster 2 through the priority 8. As shown in the slide, there were past regional activities on TB prevention and control that include initiative on the advocacy, information, education, and campaign, and technical exchange and sharing information and experiences to international forum. Upcoming activity on TB include future coordination and cooperation with external partners on tuberculosis prevention and control, and also development of the ASEAN World TB Day message. and also conduct the ASEAN TB conference. Next slide, please. For the future cooperation by external partner with the ASEAN health sector and with the ASEAN sector secretariat various at cooperation and cooperation should be aligned with the goal of the APDA 2021 to 2025, namely achievement health potential of the ASEAN community, ensure health life and promote well-being for all and all age, and also promote the wellness health system, and also provided the ASEAN community with the universal access to safe and affordable quality and holistic healthcare, as well to healthcare delivery by the adapting toward innovation and digital health technology. And lastly, the promoting of the healthcare delivery to vulnerable population. Distinguished delegates, more can be achieved if we collectively work together. Next slide, please. We wish you productive webinar. Thank you very much for your kind attention. Thank you.
Thank you, Dr. Saditan, for your excellent overview of the ASEAN goals and how the AIDP fits into that larger scheme. I will now turn over to Merinda Sebayang. Merinda is a TB survivor and the current chairperson of the Indonesia Positif, a national network of people living with HIV in Indonesia. Ms. Sebayang is also vice chair of the country coordinating mechanism of the Global Fund for Indonesia, as well as the Stop TB Partnership Community Delegation Committee. Merinda will be talking about community and civil society roles in responding to tuberculosis and other airborne infectious diseases. Over to you, Merinda, and thank you for joining us.
Thank you so much, Dr. Kenneth, for the introduction. Good day, good morning, everyone. Good afternoon, distinguished guests. Thank you so much for this opportunity. And in this short session, I would like to discuss how addressing one of Indonesia's oldest health problems, tuberculosis, which requires more than a business as usual approach. And of course, it requires meaningful inclusion of those community affected by TB. Next slide, please. It is no surprise that the past 2 years have been very difficult for all of us, including the community. And this is especially true in public health response to tuberculosis. WHO report in 2021 noted a decrease in TB case notification in multiple regions, including Southeast Asia. The report also mentioned an increase in TB deaths, reversing years of global progress. Indonesia has been identified as one of the countries most affected by the pandemic in regard to tuberculosis management, with a huge gap in case notifications showing a relative reduction of 31% from 2019 to 2020 and first half of 2021. Next slide, please. Addressing this issue needs more than just standard TB programming. It requires the inclusion of people affected by TB. They are the expert of this issue. They are living with it. They know their own needs, yet oftentimes they are ignored, not able to meaningfully participate in the design, implementation, and assessment of TB programming. Meaningful inclusion is not just their right. It will improve our TB response and significantly contribute to achieving our globally set targets of the SDGs, the UN high-level meeting, and also Indonesia's own target of TB elimination by 2030. Next slide. So I would like to share a sample of investment for the community. So in 2020, the Global Fund launched the COVID-19 Response Mechanism, or C19RM, to support responses to the pandemic, mitigate its impact on HIV, TB, malaria programs, and strengthen system for health, including strengthen system for community. The Stop TB Partnership collaborated with civil society and community groups in 18 high TB burden countries to design and implement the TB Community C19RM support package. Supported by the USAID, the package included small grants, guidance documents, virtual training session, in-country sensitization meetings, technical assistance to writing teams, ongoing engagement, and review of grant requests, and also online facilitation of South-to-South knowledge and capacity exchange. The impact of this support package was overwhelmingly positive. People affected by TB, as well as other key population, were directly included in funding requests and decision-making processes. The TB communities developed their knowledge and capacity related to the Global Fund processes. High-level advocacies related to TB community prioritized and CRG, or community rights and gender, were set in motion. The support package enabled C19RM funding requests featuring the concern of TB communities, with some countries securing significant requests for investment in TB CRG activities, such as community system strengthening, stigma reduction, and community-led monitoring. None of this was detrimental to a biomedical focus, as all teams stood by the call to emphasize on bidirectional TB and COVID-19 screening, diagnosis, treatment, and care. Next slide, please. The inclusion of affected communities has led to community-related requests that are constructed from first-hand accounts, gaining direction and accuracy, while also setting up long-term positive partnership opportunities, building the willingness of affected communities to support grant activities. However, they always challenged. They were challenged during the process. So a few TB community partners struggle to access the platform or to influence the mechanism. Community partners were most successful where there has been a long history of partnership, such as through challenge facility for civil society. Also, there was a low availability, or maybe willingness, of organizations or government partners to collaborate with TB communities in some countries. Next slide, please. Yet, despite this challenge, the support package was able to improve the level of TB community engagement and influence in the Global Fund processes. Supporting meaningful inclusion of TB communities is possible, even with limited investment, and would lead to benefits surpassing said investments. We need to scale up this investment, scale up community leadership to lead to a more organized TB communities, enabling the solution to issues impacting them. The key elements to enable these supports including ongoing investment, not just one-off events. Rapid and flexible deployment of packages while also responding to community needs, aided by the technical assistance and South-to-South knowledge exchange. This element should be standard for TB programming. Next slide, please. Next slide, please. Sorry, previous slide, please. So on a final note, I'd like to emphasize the importance of meaningful inclusion TB communities. So it is our right to participate. Supporting it is an important step to ending TB. As long as we are still marginalized, excluded, not listened to in TB responses, the solution will always fall short. Achieving targets to end TB require us to be on the table, meaningfully participating in all the steps of the TB programming. To include the community is to reaffirm the commitments to ending TB. And for my final quotes, let me read one of my favorite quotes. The minute we become an integrated whole, we look through the same eyes and we see a whole different world together. Thank you so much for your time and your kind attention. Over to you.
Thank you, Mirinda, very much, and delighted that you're able to contribute this key component of the community and civil society role. It is my distinct pleasure to introduce to you the last presenter of this first session, Sherry Vincent, who is Chief of the Tuberculosis Division in the Bureau for Global Health at USAID. Sherry has provided leadership in global tuberculosis and is a board member of the Stop TB Partnership. She will be talking about the Airborne Infection Defense Platform, the potential impact for tuberculosis, airborne infectious diseases, and pandemic preparedness. Over to you, Sherry.
Thank you, Ken. If you could pull up my slides. Yeah, great. So I think, thank you to all the previous speakers. It really has been an honor to hear you all speak. I think there's a lot of passion here and call to action. We've been through a lot over the last 2.5, 3 years. And I think people understand that we want to do whatever we can to prevent and to make sure people have the services that they need, particularly at the community level. And so I think this is, you can call it whatever you want, but this is really a way to bring everyone together that wants to be part of this and to be able to do more. And so this is where we've come up with the AIDP. It could be called anything again, but as Sahu has highlighted and Mark talked about, the next pandemic will be respiratory. And it's going to include and have an impact on TB. And the TB response and the people involved in the TB response will be called to action again. So next slide. Okay, so what is it? Again, you know, it could be called whatever, but this was something that trying to describe it the best way possible, but it's really looking at country level platforms, community level and person-centered detection for airborne infections. How can we do this better? Yes, we need new tools, but this isn't about the new tool and discovery piece that Mark was talking about. That is needed. That's desperately needed. If we had better tools, we'd be in such a better place. But this is looking at how do we use the tools that we have and the new tools that are coming out to facilitate early detection, support decentralized diagnostic networks. How do we get these new tools into the system so that the people on the ground can use them the best way possible and as early as possible? And then making sure we strengthen those links to quality care and referral services, because we may not know what they have. They're coming in with a cough. We need to make sure that there's the referral services and they're getting the care that they need. And this all falls on the backs of communities and to community healthcare workers, to the primary healthcare system, and Miranda and her groups. And so we really need to help them to be able to respond better. And they often are the ones with the least resources. All right, next slide. So what are the goals and objectives? So it's to, as I said, broaden the involvement of communities and civil society in screening, contact tracing. You know, we've been in TB talking about contact tracing for years, but COVID really kind of brought it to home. Even in the US, you know, people are now know what contact tracing is, where before it was a foreign concept. And I think in countries all around the world now, people understand the importance of that. The care, and again, the referral to improve early diagnosis, treatment, and prevention. And then to enhance the person-centered prevention and care for TB, COVID, and other respiratory diseases. And then to expand knowledge and implementation. We know if we're armed with the best practices and knowledge, we can do much better to prevent, to set up infection prevention and control measures, So knowledge is really critical. And again, at the community level, this information needs to get to the lowest level, the people that are on the front lines. Next slide. So just looking, I think people talked about this, but just to use the data to say, the overlap is overwhelming. If you look at TB incidence rates for 2020, these 8 countries have the highest incident and count for 2/3 of the global cases. I think most of you know this if you're involved in TB, but we want to bring people outside of the TB kind of community and really bring these partnerships. So looking at this and understanding this, and then the next slide, how that overlapped so much with COVID and the COVID burden. You saw a perfect overlap of pandemics between TB and COVID, and really how that was a perfect storm, particularly in Asian countries, where we saw the earliest hit of COVID and the longest of outbreaks and waves of COVID. So it really was the perfect storm. If we get another respiratory pandemic, that's going to be added on top of it. Next slide. So looking at that, I think Sahu kind of looked at the next pandemic and looking at recent outbreaks of emerging respiratory viruses in humans. You can kind of see this pathway, and just reiterating what Sahu has says, that it's going to be a perfect storm again, and it'll be respiratory. And it will have the aspect of, resistant strains. Again, to TB, that was never a question. Immediately we were like, okay, when's the next variant? And as we see the variants that are coming, it's very clear that this will continue. And so how do we deal with respiratory and a respiratory disease that is actually going to have, resistant strains and is going to have many variants? And so we need to be prepared for this. And I think this is what we're trying to think, is this is one small piece at the community level that could be could help for that preparedness. And I know that Mark was talking about the bigger kind of global agenda, that we really need to have a global initiative that this could nicely fit in. But this is more of a community-based kind of approach that maybe will provide lessons learned for if there is a more global initiative. Next slide. So again, it's using, what do we know? What do we have? How can we play our part? How can we use the lessons learned from the decades of building up TB programs, but also what has happened in the last two to 3 years on, COVID being built on top of the TB platform? So how can we do better? How can we make sure that we're using all of our tools and that we're not overwhelming our community and primary healthcare systems, but we're building up them to be better and stronger? And so that's really what this is about. Next slide. So I think I went through this slide. Sorry, keep going. In the interest of time. So just getting to practical, how could it work? This is just one example, and there's more, but we just wanted to kind of give this example. And obviously, as new tools become available, we will be able to do more. But this is really, how do we engage the community, the groups like Miranda, and others, to generate the demand, to make sure that they're educating people with symptoms, getting them to the right place to access and to address their issues. And as many of you know, there's new technology of digital portable x-rays that have artificial intelligence, AI component to it, that require minimal facility, a minimal healthcare worker support, and can be done to actually look at, how can we leverage the diagnostic network platform? So using that, and then looking at, okay, if it's TB, great, including any subclinical that will diagnose it. But if it's not TB, then identification of other pulmonary diseases using this community-based tool that can go out beyond beyond a primary healthcare facility and be in mobile units or just by individuals going door to door to clinics or to events. And then other advantages are, you know, the detection of cardiopulmonary and other medical issues that you can detect with the digital X-ray. So it really can expand the services of a healthcare worker going out into the community. And then you need the near point of care. It's not quite point of care, but molecular platforms that can also be looking at. You refer to those. We now have Gene Expert, TrueNat, and hopefully others. And then there's the rapid diagnostics for COVID. So making sure that then you're referring and getting people to whatever care that they need. So this is kind of one option, one way that AIDP can help, really focusing on building these networks across the countries, very low level and into the communities. Next slide. So that's just a kind of snapshot of the AIDP. Again, we want partners to come together. As you heard of the different organizations and individuals that spoke already, there's a need for us to come together and to do innovative things, to do things a bit differently, bring all of our resources, but particularly focused on the community and a person-centered approach. So thank you very much for your time. And I look forward to questions and the rest of the webinar.
Thank you, Sherry, very much for this great presentation, providing the framework beyond the conceptual framework, but looking at the practicalities of implementing the AIDP. We do have now about 12 minutes remaining to answer any questions or comments that participants might have, and before we move into the second session of today's webinar. So I first want to acknowledge that several questions have been coming up in the chat box. I'm thankful to both Tara Ornstein and Sahu Suvanan, who've been replying to them. I saw that Marinda has also replied. So this has been active participation throughout this. But let me pause here and ask if anyone has any questions, please either raise your hand or indicate. Probably the best thing is in the chat box because we have about 170 participants and I don't have every single tile showing up on my screen. So if you can make use of the chat box, I would appreciate that for questions that people might have. Falguni Sunaram has some concluding comments, and why don't you go ahead?
Thank you, Pami. Actually, I want to conclude here that according to me, government should committed to do social protection includes public action that address poverty, income shocks, and social vulnerability, taking into account the relationship between exclusion and poverty through income or in-kind support, and program designed to increase access to service, social protection to help realize people's rights. Under the umbrella of social protection is social support, which includes various strategies for supporting people throughout the course of their TB care. Examples of common social support strategies for TB include patient support, financial support, health education, psychological support. And by endorsing the UN political declaration on UNHC, government have committed to stop the rise and reverse the trend of catastrophic out-of-pocket health expenditure by providing measures to assure financial risk protection and eliminate improvement due to health-related expenses by 2030, with special emphasis on the poor as well as those who are vulnerable or in vulnerable situation by endorsing the and strength, support, and capacity building in countries that have social protection system with limited resources, and help developing countries raise domestic revenue and provide bilateral financial support towards achieving UNHC and social protection strategy. And thank you for giving.
Thank you
me
very
the-
much for, thank you for your comment. Obviously, addressing social protection is going to be a key component. And we've already seen that even during the COVID response when people were asked to stay home and didn't have an income. In the case of tuberculosis, we've seen how this disease has preyed on the impoverished and the marginalized, and there's always a need to offer some social protection. So you bring up a very excellent and important point. I did see, Mirinda, with your body language that you apparently had something to say, or am I putting you on the spot? You're welcome to if you want to.
Well, I just have a very short comment. Actually, yes, I really agree that the government should provide the social protections for all the citizens, not only for the community, of course, for all the citizens. And this situation also, we still have challenge also in our country, because I just recently come from the meeting with the community, and they raised that it's really difficult for them to have the ID card. So if they don't have the ID card, how can they access the social protection itself? So yes, I really agree that the government should put in place that the rights of the society, of the community should be they're prioritized, so the community can access to the health facilities. Over.
Thank you, Mirinda. I don't know if anyone of the other speakers has any additional comments. Sherry, go ahead, please.
Sorry, I can't find my hand, so just raise it. So I think it is really important. I think many countries are trying to get to including TB into the health insurance packages, which is really important. And I think we need to make sure, because people with TB actually pay higher out-of-pocket costs than many other illnesses. And that's a lot due to the diagnosis piece and the long treatment. And so I think we just need to make sure that we're trying to reduce the out-of-pocket cost. You know, TB affects more people with poverty. So I think that's also really important. But I really congratulate the Indonesian government. They focused this call to action on TB financing. And I think that is really needed to be able to get, you know, the support to every citizen that needs it. And so I really hope that that call to action will lead to some statement in the final G20 declaration of the ministers, because we need to make sure that people have the support that they need, not just for the drugs, but for everything that's required. Thank you.
Thank you, Sherry. I'm observing that the Chimazi Dimka from Nigeria shared in the comments how in Nigeria they utilize a screening pathway model where they combine chest X-ray TB screening with simultaneous COVID-19 testing. And as a TB organization, they work with Breakthrough Action and provide COVID-19 screening services for enrollees who receive X-ray screening immediately. They exit a mobile digital X-ray truck fitted with computer-assisted diagnostics. And that way he's saying they don't miss out on both TB and COVID presumptive. So this is pretty much consistent with the framework of AIDP, except that we would expand it beyond just tuberculosis and COVID-19 diagnosis and services, as well as referrals. I think I see another question. Stefan Goldberg is saying, thank you for the meeting and great presentations. Key items in last two were meaningful inclusion and generate demand. How do we help generate demand? So I will turn it over to Sherry, because that was part of your presentation, and maybe Mirinda or someone else wants to talk about meaningful inclusion.
Maybe Sahu on that demand,
okay,
piece, and Mirinda.
Okay, Sahu.
So thank you, Ken. So I think the question here also on the chat was very interesting about community empowerment and not just community engagement, because empowerment means that you empower the community by investing on the community, giving them the equipment, the knowledge, the tools that are required for them to get meaningfully involved in the response that we want them to be involved. TB has done that for some time. Recently, if you look at TB historically, there was very little investment, but in the last few years, there has been a lot of investment on empowering communities to act. And I think the challenge facility for civil society at Stop TB Partnership is a good one to look at. A number of civil society, community, TB affected community partners in many high TB burden countries have benefited from the challenge facility. And thanks to USAID for the generous support and for other donors also for the challenge facility. Thank you.
Thank you, Sahu. Myrna, do you want to talk some more about the meaningful engagement? Don't mean to put you on the spot, but.
Yeah, I think from my side, the meaningful engagement, it also have to come from the community itself. I mean, the stakeholders, the partners maybe can provide the support, the tools, but if there is no willingness, if there is no courage from the community itself, it's still, I think, there will be a lot of problems with that. So from my side, the community has to empower their self too. They have to increase their knowledge and also grab the podium, come to the meetings, ask for their rights, because everybody can provide any tools, any support, any investment, any money. But if the community don't want to grab it, don't want to take it, it's also meaningless. That's from my opinion. Over.
Thank you. I also want to acknowledge that Falguni Sudaram has provided other extensive comments in the chat box. So participants are welcome to take a look at that. That complements what he's already mentioned during his intervention. Let's see. The last comment I see in the chat box is, as part of prevention of community transmission and contact tracing, how can we encourage the uptake of TPT, which is TB preventive therapy? Does anyone want to take this on?
Do you want to go, Sahu, or you want me to?
Yeah, I can go. So I think that's a great question. TB preventive treatment, for this, there is a UN high-level meeting 2018 target. 30 million people have to be put on TB preventive treatment, but currently we are not on course. Countries are not on course to meet that target. It is very clear, especially in the group, which is contacts. So I think more is required in the area of putting contacts on TB preventive therapy. We must remember that every TB patient was a contact in the first place, right? And we must also remember that to start TB preventive therapy, we must do a contact tracing or contact investigation. And this is something that has not been happening in TB programs consistently. Now with the onset of COVID, the importance of contact tracing has even become more important. So anything that is done to systematically do contact investigation, contact tracing in TB will also help for contact tracing for other infectious diseases. And that this is one way of getting to detect disease early, and therefore you can prevent. And in the case of TB, you can give a preventive therapy to decrease the risk of getting TB for a contact. This is something that has not happened with good priority and political commitment in the past, but this is very important. And in the context that we are discussing, airborne infection defense, this is an important tool that should be happening, much more at a scaled and intensive way. And I must also point out one other thing. During the COVID pandemic, many of us saw this, I think all of us saw this issue about vaccine hesitancy. There is also a TB preventive treatment hesitancy amongst providers, amongst people who should take it, because these are healthy contacts, right? So this is also something that we have to work on. The TPT, the so-called TPT hesitancy needs to be addressed. Thank you.
Yeah, maybe I can just add, I mean, what we're talking about here, we haven't gone into detail, but, lung health is really critical. I mean, we've seen this. And so it's really important that we treat all of TB. And that includes preventative therapy. And I think, contact investigation is the way to start, but then you need to make sure that all those contacts that are eligible according to WHO guidelines need to be included in national guidelines, and they need to have access. I know resources are limited and that is an issue, but if we don't address this, then, we are putting people in vulnerable positions. And their chances of getting TB are much higher, of getting active TB, and may be risk for other respiratory diseases. So I think we need to make sure that we're finding the resources to do that, and we're including everyone that should be eligible for preventive therapy in the guidelines, and making sure it happens.
Thank you. I'm mindful of the time that we're going to need to wrap this up. I wanted to acknowledge Dr. Sadetan, who was the main focal point of the ASEAN senior official member and health department, for her interventions. And as you well know, this T-20 has been part of the ASEAN Secretariat. And I wanted to acknowledge that, even though we didn't have any specific questions for you, certainly welcome your participation and engagement. With this, I'm going to exercise my role as chair and wrap this up, invite us to move into the next session 2, entitled Tuberculosis Screening and Diagnosis, looking at new tools and approaches to identify airborne respiratory pathogens through an expanded community approach. The first presenter for this session is Dr. Bill Rodriguez, who is CEO at FIND. He's a physician, and FIND is the Global Alliance for Diagnostics. Dr. Rodriguez has served as an advisor to the World Health Organization, the Gates Foundation, and national governments on global HIV, tuberculosis, Ebola, and COVID-19. Bill is going to talk about using tuberculosis platforms and new tools to diagnose airborne infections and other respiratory diseases. Take it away, Bill. The floor is yours. Thank you for joining us.
Thank you very much, Ken. And also thank you to our host at the T20 in Indonesia, and good day and good morning and good afternoon to the esteemed colleagues on the webinar. I appreciate the invitation and the chance to participate in today's session. Next slide, please. I know everyone is familiar with FIND, and just as a reminder, while we've played a leadership role in the global response to COVID with respect to diagnostic testing, like all of you, we have not forgotten about the other high burden and high impact diseases in the world that have surged under the pandemic. And so while FIND's work to address the diagnostics gaps over the past few years have been really compromised by COVID, especially in TB control, we've heard other speakers say, there actually have been major positive developments in testing that I want to highlight today, and talk about the implications for TB and disease control in general. Next slide. Sahu did a great job going through kind of the overview of what we've seen with testing platforms, but unsurprisingly, as you all know, since they're both transmissible airborne pathogens, almost every technology platform that we've used to detect and diagnose TB has been repurposed in the past 2 years to respond to the COVID pandemic. And given those developments, what I think is critical, and I'll come back to this later in this talk, we can no longer think of TB diagnostic platforms. Really, if we want to strengthen the approach to detect TB and COVID-19 and other airborne pathogens in an integrated way, that will make the isolated efforts to control TB or COVID-19 or prepare for the next pandemic even more valuable and more successful. And that's the critical stage we're at today, given where we are with technology innovation in diagnostics. That requires a frame shift in our thinking about diagnosing TB and other diseases. TB is one of many airborne pathogens rather than a pathogen that exists in isolation. In my read on the AIDP is that it's just this sort of rethink in our approach that's being supported and pushed by this initiative. So I really appreciate the thinking that's gone into it. Next slide, please. And I'll come back to that and how to think about that in just a second. So we show this slide frequently at FIND, and it just highlights the very simple point that when you try to increase access to testing at the community level, as you move down this slide from a centralized laboratory or a referral hospital down towards the community and towards the home, generally that comes at a cost and performance of tests. And that's true whether you're thinking about any clinical diagnostic test or antigen-based or antibody-based testing for seroprevalence studies, or molecular tests and sequencing that can identify pathogens at a molecular level and track variants, as we've seen under COVID. However, optimizing performance and optimizing access together proves to be a very fertile landscape for innovation. And that's been dramatically accelerated in the past 2 years by the pandemic. Next slide. So from a technology perspective, pre-pandemic, just not even 3 years ago, we really only had a few types of diagnostic tests and platforms that could address airborne pathogens. And those tests were not available in the communities where people live and where people work and where people attend school and where people seek care across the world. They just didn't reach quite that far. Next slide. I'll spare you the technical details, but what you see on this slide is really an explosion of new methods in diagnostics that has emerged in the past 2 to 3 years. Colorimetric and electrochemical techniques and sample processing techniques. We have old technologies and new formats that are simpler and smaller and easier to use and less expensive to manufacture. We have new techniques and ultra-fast sample processing technologies, the sum of which is what used to take 1 hour in a large machine in a central laboratory operated by a specialized technician really does now take 10 to 15 minutes in a small box in a clinic. And we've seen that. Many of us have experienced that directly through testing ourselves or our friends or families and communities during the past 2 years. We're also seeing the genomics revolution reach much further than we anticipated, much faster than we anticipated, with sequencing technologies now accessible and linked to where patients are being seen, driven in large part by the need to track variants in COVID. We have more integrated digital tools faster than maybe we expected, that link patients and providers and test results in efficient ways. And so compared to just 2 years ago, at last count, and this was a few months ago, there are at least now 56 novel near patient molecular test platforms that have been launched and received a regulatory clearance that can detect SARS-CoV-2 and other pandemic pathogens and other airborne pathogens, including at least 15 novel technology platforms that are truly usable at a primary care level anywhere in the world. So it's really not an exaggeration to say that COVID has accelerated what should prove to be the third revolution in diagnostics technology for all diseases, not just COVID, not just TB, not just airborne pathogens, but all pathogens and all diseases. Next slide. So what are the implications of that for how we've approached testing in the past before this new wave of technologies? And so I love the concept of AIDP because I think it aligns so well with these emerging technologies and a new approach to testing, including for TB. And I think what's highlighted here are the 3 levels at which we think that should occur. The first is we've seen what happens in COVID when we empower patients. The nature of self-tests, which have been used in HIV and in some other diseases, hepatitis C and some of the STDs, exploded under COVID in certain settings. And we've seen that when patients have tools to protect themselves, test themselves, the information to know what to do with a test result, they invariably make good decisions about their own health. And we need to empower patients to be engaged more directly in the testing process for TB and for every disease. Second is when we enable the healthcare workers at the front lines at a primary care level, and we provide them with accurate, reliable, affordable, simple tools to do timely screening and timely diagnosis and to quickly link people to appropriate care. We also see the impact on disease control and the opportunity ahead of us with these new systems and new technologies. And then lastly, what we've seen is when we link clinical care with the public health response, epidemiologic testing and surveillance at a primary care level, we can improve both our ability to respond to patient needs with an individual clinical condition and access to treatment, with the needs of the public health system to monitor disease spread and to apply resources to disease control. Next slide. So this is a very simple slide, but I think it makes a profound statement for those of us who've been working in diagnostics for a long time. And that is, we all know that patients don't show up at their local clinic asking to be tested for Nipah virus or TB or COVID, although we've seen what happens when they do come in for COVID testing. Really, they show up because they're not feeling well. They have a fever, they have a bad headache, they have a cough, they're symptomatic in some way, they've been exposed to someone else who's sick, and they want to know what's wrong. And so we've long imagined, what if we had a single test that could be used from a single sample to diagnose not just COVID or not just TB, but any airborne disease, any epidemic-prone pathogen from one sample at a primary care facility. And really, that's another way of saying, imagine if our health systems and our diagnostic systems were structured around patients and not around diseases. Next slide. So the truth is, whether or not we're ready for it, the technologies for doing just that, for detecting multiple diseases from one sample at a primary care level in any part of the world, they're here, and they're going to force us to change our approach to airborne pathogens like TB. We've long held that out as an aspirational goal, that testing should be patient-centric and decentralized, but it really is a reality, not in 10 years, not in 5 years, not even in 2 years, but now in 2022. And I'll let you know, especially in 2023, when multiple new COVID-driven platforms that can do multiplex testing at a primary care center are going to come to market and complete their clinical trials and their regulatory authorizations. Next slide. That said, these tests exist in a market, and the tests and the equipment and the training and the delivery programs and the supply chains that will support this effort, they can be rolled out in a coordinated, well-designed global program that emphasizes equity and access and links to care and treatment and links to public health systems and surveillance and are patient-focused and patient-centric, or not. Or they can be rolled out in an uncoordinated way that doesn't emphasize equity and access and patients. Next slide. So the AIDP, I think, is really an effort to do the former, to really try to coordinate a global response, including diagnostic testing, leveraging what's happened under COVID and these new technologies. And I just want to highlight in the last few slides, what do we have to do to get there? What's left to do? And this is really essential. And this is a slide on COVID, but we have to acknowledge the reality is everything that I've just said is shown on the chart on the right. It's quite different, the reality, than the potential that I've been talking about. The reality is that the fruits of diagnostic innovation of the last 3 years have not been shared equally in the pandemic, but inequity is growing rapidly. And the wealthy people in wealthy countries have had much more access to new tools for diagnostics for airborne pathogens than the rest of the world. And that is an urgent crisis that continues today. Next slide. And then a final point I want to make that's unappreciated is access to diagnostic tests that we've seen under COVID and will be true for TB and other airborne pathogens and all diseases. There's a number of new healthcare delivery models emerging across the world that are, especially in high burden TB countries, and their role in improving access to testing is critical for us to engage with and understand. And that's a major approach that hasn't yet been fully embraced by the diagnostics community, all of us who work in disease control around the world. Care is being delivered through workplaces and pharmacies and retail networks that are leveraging these new tools. And we need to think holistically around all the models where patients seek and access care, because the technologies are now going to support it. So the question for us, and it's something we talk about regularly at FIND, is how do we leverage those models, those service delivery models, to increase equitable access to testing and to drive the agenda around disease control in an integrated fashion. So I'll stop there. I think I wanted to highlight just the positive developments we've seen under COVID and how that has now created a new opportunity that's here. And it's on all of us, incumbent on all of us, to address that in a coordinated way. And I'm looking forward to engaging with the AIDP and appreciate the efforts of the USAID team to drive this agenda and make this webinar happen. And I look forward to what we can do together in the coming months and years. Thank you very much.
Bill, thank you so much. You've covered very nicely with a very optimistic outlook what we should be expecting. And I love the fact that you also introduced the concept of needing to pay attention to equity, so that we don't only have the worried well accessing the tests, but those who need it the most should have access to these. Let me now turn over to our next presenter, Dr. Raghuram Rao. Dear colleague from India, Dr. Rao is the Assistant Director of the Central TB Division in the Government of India's Ministry of Health and Family Welfare. He's a member of the Stop TB Partnership, and he will be talking to us about employing diagnostic networks to rapidly detect multiple airborne infectious pathogens, using the experience of India as an example. Over to you, Dr. Rao. The sound is not very clear. I don't know if it's a function of the microphone or what.
Hello.
Okay, we heard you say hello.
Yeah. Audible now?
We're having
Hello.
trouble.
Yeah. Yeah. I hope I am visible now and audible. So thanks.
Now it's a lot better. Go ahead.
Yeah. Thank you. Sorry for the inconvenience caused. So I'll speak about something that we have done in India, and the way diagnostic networks that we have and that we scaled up during COVID has helped us improve and scale the TB program. Can you have the next slide, please? Yeah. So what we had in COVID, there were very clear two waves. The first time when we had it in 2020, you'll see in the month of March end and in April, we touched rock bottom. If you see there are two lines. The upper graph is on the drug sensitive TB notification, and the lower one is on the drug resistant TB notification. And in both places, you'll see that in the month of March, April, May, we had literal disruption in services that happened, and then it took us almost a year, almost to the end of December in 2020 to recover back to pre-COVID levels. Whereas in spite of a harsher wave in 21, we were immediately able to respond back the next month itself, in the month of June, after a rock bottom in May, and similarly in the DRTB side. And this has been possible with the extra effort and the mitigation measures. We move to the next slide, please. that we had deployed, under the program to ensure that the adverse effect of COVID, although the response that we gave for COVID was intentional and it was required, it was the need of the hour, but we also needed to ensure that the services that are being provided apart from COVID does not get disrupted, and in the environment of a lockdown and restrictions to community movement, population movement, and transport, all those things, we had to ensure that the cases that were already notified and on treatment do not get a disruption and their treatment continues. And at the same time, we do not miss out finding new cases, because otherwise the population is restricted within the household and they will continue to spread infection within the house. So we had to ensure both sides in ensuring that the case finding is not impacted and the same time case holding is also measured. So we had targeted activities to ensure that the advanced directives right up to the district level, and ensuring that there is bi-directional screening for TB and COVID, because both had a clinical overlap, symptomatic overlap, and needing to rule out each other was extremely important. And also to use the mechanisms for COVID surveillance and the population which was symptomatic, like the cases with ILI or SARI, or known COVID cases, or presumptive cases, making sure that TB screening is done for all this population, and also scaled up our molecular labs. We did have to, during the peak of the waves, repurpose our lab network to provide COVID services. And because of the molecular technologies that we had and the scale up of these molecular technologies also had to be done during COVID. And this helped us ensure that the TB program doesn't get compromised to a large extent. And we also at the same time ensure that the COVID case finding doesn't get disrupted. So that's the part where our diagnostic network took a major boost, and the same lab was providing both TB and COVID services. And we went below the block level, below the district level, which is the third tier, the blocks, then the districts, and at the state level. So that three-tier structure that we had for public health, we ensured that we reach to the bottom possible level with molecular diagnostics, and ensuring that there is active case finding, and ensuring that it is integrated surveillance, be it for COVID or for TB. And when we are knocking somebody's door to look for COVID or to do contact tracing for COVID, we also ensure that we don't miss out on TB questions, and ensure that we do case finding on TB also over there. And of course, there was a lot of innovations in the field that happened to ensure that the drug is made available. So giving extended duration of treatment. Otherwise, we were following DOT for TB, but then we had to modify our strategy to move from directly observed treatment to remotely observed treatment. And although it may not sound nice, but dots versus rots, like I said, but it was not rotting. It was helping the system remotely monitor adherence to treatment. So these were a lot of innovations that happened, and the mitigation measures that we took. Next slide, please. Also, going forward, in spite of the knowing the fact that COVID is going to be there and we have to live with this for the times to come, we ensured that the clinical guidance or the management protocols for COVID-19 very clearly indicates that we have to rule out active TB as a disease, because it has an adverse impact on the mortality, and we had to ensure that if the symptoms persist. So these are making sure that we investigate for tuberculosis. So these are recommendations in the clinical guidance that we have, and also going forward to not just manage the case, but to ensure that we follow up even COVID positive patients at 6-monthly intervals to make sure that the post-COVID sequelae and early screening for TB at that point of time happens, and also to for post-TB treatment to make sure that at 6-monthly intervals we follow up for both diseases and make sure that the population is safe. Next slide, please. Yeah, so with that opportunities that we had to summarize, if I were to say in the COVID era, apart from lab strengthening, platform technologies was a huge boost, where with the same technology, we were able to screen for multiple diseases and communicable diseases. I'll be speaking a couple of slides on that also after this. And what we did was use the emergency COVID response funds to also scale up technologies which could be useful for the TB program, especially the molecular diagnostics and point of care tests that we could see. And the other advantage that we had was a lot of human resource in the public health system was enhanced and trained to be able to handle communicable diseases. So that's something which is going to help the system in the long run, and making sure that the public health surveillance going without focusing on certain disease, but when we are knocking doors doing community surveillance for communicable diseases, it should be public health surveillance and multi-disease screening happens over there. Next slide. And apart from this, also making sure that the airborne infection control measures that otherwise was something which was required for TB, it's now something which is understood by the system, by the administration, by the bureaucracy. And so now we are able to scale up airborne infection control measures at health facilities, which again in the long run is going to help for TB programs, and also sustaining the community behavior, the COVID appropriate behavior that we have, and ensuring that we convert that into TB appropriate behavior, sustain the physical distancing, the the ban on spitting, for example, and the hand hygiene. Everything is going to help us in handling communicable diseases. So that's something which we are looking at sustaining, and also the introduction of technology, and be it on the diagnostic front or on the treatment front. Like I said, adherence, we were using remotely observing the treatment adherence by various tools. We had multiple tools for doing that, and plus a lot of tools on AI and your point of care tests that were introduced during the COVID one. So that has helped us improve TB performance also. Next slide. So, like I said earlier, a lot of molecular technologies have come in, which are platform technologies, be it the Gene Expert and the TrueNat that we had in India, which is introduced for TB. But all these technologies and all the RT-PCR systems that we have are, are able to perform tests for a host of infections, communicable diseases, and this infrastructure building that has happened is definitely going to help, the TB program and communicable disease programs in the long run. Next. And also to ensure that these technologies are, there's one slide on the scale up of performance that we did. We largely focused on scaling up TrueNat in the health system. And in 2021, if you see the huge scale up of molecular labs that we did on TrueNat, and now we almost have more than 3,500 odd labs across the country, and reaching all districts and even going below the district level. And at the same time, you can see the number of tests that has increased. Though 2020 and 2021 was a COVID impacted year, we still had, and these machines were also repurposed, but it helped us decentralize transition away from sputum microscopy as the primary tool. So it's happening in phased manner across the country. Next slide. And like I said earlier, a host of diseases that these technologies are able to do, be it for SARS-CoV or viral hepatitis B, C, oncology, HPV, a lot of other tests, both be it Gene Expert or be it TrueNat, and even all the other equipments like, the RT-PCR machines. We are looking at utilizing those high throughput machines also for TB, and having a robust supply chain mechanism, sample transportation mechanism, to make sure that we are able to improve and scale up molecular diagnostics at decentralized levels in the health system. Next. The infrastructure, of course, the infrastructure boost that has happened because of COVID in India. What we have done is we have introduced this concept of public health laboratories, integrated public health laboratories at the subnational level, at the district level, and at the block level. And the resources that were mobilized for COVID, the emergency COVID response front, and the preparedness of the health system to be able to handle future epidemics of such nature, the infrastructure is being built across the entire country with what we are calling as integrated public health laboratories. Next slide, please. And this integration is happening in all three parameters. The physical integration, which is under one roof, having all the laboratories and integrated laboratory across technologies, across disease platforms, and then also functional integration in terms of the vertical programs that we had for TB or HIV and all those things. Integrating that and having one IT system, a laboratory information management system, through which all the data across programs and is going to help handle our the public health needs at the subnational levels. These labs are going to provide all sorts of services with the routine clinical pathology, hematology, cytology, microbiology, biochemistry across these services, both in OPD and IPD form, is envisaged to be provided under these integrated public health laboratories. Next slide. Now they have both upward and downward linkages. The plan that we have is that the integrated public health laboratory at the district level will have the spokes, which would be the block public health laboratories, and from there the further sub spokes would be the primary healthcare settings. The community health centers and the primary health centers, including the health and wellness centers. That is the bottommost unit of the health infrastructure in India, which is at the sub-health center at a population of around 5,000. From there right up to the district level is the downward linkages that we have through these integrated public health laboratories. And next slide, please. The upward linkages of these laboratories at the district level then will are linked to higher level centers at the state level and called the state public health laboratories. And then for multiple regions, we will have regional public health laboratories and national apex laboratories. So to ensure that right from the peripheral level in the public health system, we are able to handle any emergencies, and the system is capacity to handle future pandemics of this sort. Next. Yeah, so like I said, so making sure that the TB program, of course, it's like, because we are so focused on TB and advanced our targets of SDGs by 5 years to try to achieve the SDG indicators by 2025, our systems involvement and strengthening this is required. So making sure that the system, the platform technologies, the experiences that we have learned from COVID and the newer and the additional human resource and infrastructure that has been set because of COVID, is the system is able to take care of any future airborne or otherwise pandemics that may occur across populations. And of course, also decentralizing to make sure that the outbreaks are managed at the bottommost level possible. And these laboratories and these foot soldiers that we will have will always be mutually working for handling not just TB but all communicable diseases. So it's a skilled manpower and infrastructure with platform technologies. So that's the way forward that we are looking at in India. Next slide, please. Yeah, so that's broadly what I wanted to share, and I hope if there are any questions, I should be able to answer that. Thank you.
Thank you very much, Dr. Rao, for sharing with us the experience in India, which establishes really a proof of principle. And you've also shared how you've integrated your public health laboratories to achieve improvements in diagnostics. Let me now move to the next presenter, Chobsok Cameron, who is the Executive Director of Khanna in Cambodia. Mr. Cameron is actively involved in TB advocacy as the co-chair of the Activist Coalition on TB in the Asian Pacific. He's also one of the members of the WHO Civil Society Task Force for Tuberculosis and the Developing Country Non-Governmental Organization representative for the Stop TB Partnership. We will hear from Cameron contact investigations and active case finding community perspective. The floor is yours, Cameron, and thank you for joining us.
Thank you so much, Professor Ken, and good morning, good afternoon, good evening. And so first, I would like to thank to USAID and also the Stop TB Partnership, as well as T-20 Indonesia 2022 for allowing me to be part of this discussion. And like Professor Ken mentioned, I will talk about contact investigation and active case finding from the experience that we are doing here in Cambodia. Next slide, please. So in this presentation, I will talk about why it is used and who involved in this contact investigation and active case finding activity for TB, what contribution have made over time, especially on the result from our learning on the ground, and how to sustain the response using this contact investigation and active case finding activity for TB. Next slide, please. So contact investigation and active case finding activity for TB, actually it is being used under the 5-year USAID funded commit project that Khanna is planned together with other 3 organizations implementing this project in 10 underserved operational health districts of 3 provinces and municipality of Cambodia. And this project actually to improve access to high quality patient-centered TB, drug-resistant TB, and TB and HIV services, and strengthen TB service delivery platform. We use TB transmission and disease progression, and accelerate TB research and innovation that positively impact program implementation. For contact investigation and active case finding activity for TB, it is actually to follow tracing those who missing the TB care services, to screen and identify who is infected and living with the disease, including those DSTB and MDR-TB. And actually, it is the same approach that are also used for other pandemic prevention, preparedness, and response. Next slide, please. Contact investigation and active case finding for TB involve, in our case, in addition to the support from the national program, from the provincial health department, district health office, we work closely with health center staff and engage community health care provider, which include lay counselor, a snowball team, which they themselves are people living with and experiencing TB, peer support group, the same. They are the people that are living with and experiencing TB, the district network of people living with and experiencing TB, village health support group, mobile outreach ACF team, local authority, and other key people member in community. Next slide, please. So this just only some picture of the active case finding that are being implemented in rural Cambodia, where the X-ray machine and gen expert machine are brought to where the community are, so then it can make the community easy to access and get tests and diagnose, and then support them to enroll to the treatment, where we collaborate closely with the health center where the medication is provided over there. Next slide, please. And again, this is just some photo of community TB screening at one of the village. And below are is the mobile ACF activity including the sensitization activities, screening of TB symptoms that refer by village health support group in community, and some of the photo explaining the collection of sputum for gen expert tests. Next slide, please. So, and this one just a photo of lay counselor. Like I said, they themselves people recruit from community, and they experience living and with TB, and they support health center chief to perform contact investigation at village. And this is just example in one of the village in one of the district where we conduct this investigation, contact investigation in early this year. Next slide, please. So through contact investigation and active case finding for TB, actually they have contributed a lot for TB program, especially get connect with those who are at higher risk at early stage with their peer and in a friendly manner. Because like I said, you know, most of the people involved in contact investigation as well as in active case finding are the people they themselves experience living with and affected by TB. And it is a way that brings the most and modern TB diagnostic tool close to the client and where they live, get our stakeholder engaged in TB care beyond health. Because when we conduct these two activities, we also involve local, in addition to local health authority, we also involve other key community members, including local authority as well, religious group, so that they can support and they can providing, you know, some sort of activity related to stigma and discrimination, for example, you know, against stigma and discrimination for people living with TB. And enhance and intensify TB missing case and get them to the service immediately. And especially these two activities have the close contact access to TB tests, diagnosis and treatment, including the LTBI, TBT, as well as other health benefit and social protection scheme. Because we brought other people beyond health to come and involve in this activity, and then if those people with TB, they need any other health benefit and social protection scheme, then we support and we facilitate the access to those services. Next slide, please. So this is just example of the project that funded by USAID, in particular of under the commit project, and this is a result in 9 months from October 21 to June 2022. We screened over 72,000 people, and we identify around 20,000 who are presenting TB, and then we facilitate over 90%, 98% of those to get tests, and we detect, you know, all form of TB, about almost 2,000 people with all form TB, and among them over 30% are bacteriologically confirmed TB. In addition to that, we have about 23% of those detected are childhood TB, and almost 100% of those people that detect with TB facilitate to enroll into treatment. Next slide, please. So through this contact investigation, you would see among the 386 TB index cases that identify, we have more than 2,000 close contact are notified, and over almost 96% of them screened, and we identify that almost 84% are eligible for TPT, and then 78% enroll onto TPT. So through this, we also identify people who are presenting TB, and we test 164, and then additional 23 people are detected with TB. So these contact investigation and active case finding are really, really important to get people onto TB care services immediately. Next slide, please. So therefore, it is very, very important that this kind of response, this kind of activity should sustain. And from our experience of doing the services on the ground, we learned that invest both funding and technical assistance to CSO and affected community to continue their role in contact investigation and active case finding for TB activity are really, really important. And it needs to prioritize TB in the center of pandemic prevention, preparedness, and response. For example, in our case, even though COVID-19 pandemic, but the national program, the government, still continue to work alongside with partners, including our project to make sure that services for TB continue to offer to those people in need. So therefore, it is very important that TB should be prioritized in the center of this pandemic prevention, preparedness, and response. The other lesson learned is that to sustain the response, it is very important that we need to roll out community right and gender for TB in the contact investigation as well as in active case finding, where TB affected community are owned, led, and monitor the response. And the other aspect is we need to decentralize TB services and integrate TB into the primary healthcare initiative, because we learned that working closely with health center staff, they at the lower level is really important. So it's to build the system, but also to get them on board and initiate how this TB can be integrated wisely into the existing public health system and respond as well as the pandemic response. And last but not least is the Fund TB program. We learned that Fund TB program is an investment, and we don't see that this should be an expense, because these people are also really need the TB services. Next slide, please. Oh, that's all. So once again, thanks a lot for your attention, and our special thanks to our NTP program, National Center for Tuberculosis and Leprosy Control, SINAP, and our partner, Cambodian Health Community Center for Health and Social Development, Cambodian Anti-Tuberculosis Association, and especially our funder, USAID, and the Stop TB Partnership for all their funding support and technical assistance to allow us to do this job in the community. Thank you once again, and back to you, Professor Ken. Thank you.
Thank you, Cameron, very much for your excellent overview and presentation of the way that your contact investigations and active case finding have been taking place from a community perspective. I'd like to now introduce the last presenter of this session, Ms. Zisan Kin, who is the digital health specialist with the Stop TB Partnership. Zisan works to ensure that Stop TB Partnership plays a leading and coordinating role with global stakeholders to introduce, scale, and expand access to appropriate digital solutions for tuberculosis in order to reach the UN high-level mission targets. Zisan is going to be presenting on the potential for artificial intelligence imaging in tuberculosis and beyond. The floor is yours, Zisan, and thanks for joining us today.
Thank you, Chair. And Honorable Minister, distinguished speaker, and ladies and gentlemen, in the next few slides, we hope to show you the application of the AI imaging in TB and its potential in pandemic preparedness. Next slides, please. AI, or artificial intelligence, is no longer science fiction. It has been increasingly prevalent in all aspects of business and society. I think this is really an application of technology that Sherry has mentioned before as an existing technology that we don't need to reinvent the wheel, but we could apply and look into this application to amplify the use of utility of the technology. So AI technology has multiple applications and it started to be using in healthcare, increasingly be used in healthcare. And it has a lot of potential to transform many aspects of patient care. In general, the key application of AI in imaging use a type of subtype of AI technology called deep learning. And this type of technology can recognize pattern using AI algorithm in imaging or data to give you automatic insights for healthcare providers. There are some use cases of AI imaging that's listed on this slide that includes early diagnosis, detection, decision-making, treatment, and patient management, etc. Next slide, please. As one of the world's highest growing industry, AI in healthcare has a market value of 8.2 billion in 2020, and is projected to reach close to 200 billion in 2030. This represents a growth rate, annual growth rate of 38.1% from this year on the next in the next one decade. In a study that has been shown, conducted by Roche, it's been highlighted AI as one of the most destructive technology in healthcare in general. As AI is getting increasingly sophisticated, it is able to start doing things that human can already do, but more efficiently and much more quickly, and at much more lower cost. And it has potential in bringing health equity in a lot of countries that are being usually neglected, and in the disease area such as TB that has not often received a lot of attentions. Next slide, please. So now everybody have heard about one or two application of AI, but I think really the use case of AI in TB represents a good example of technology, does new innovation does exist in TB, and how it can transform the impacts, public health impact, that have spillover impact and affects the other disease area, including other airborne diseases. So as early as the early 2010s, before AI was a hit and hype in the society, there's a type of technology called computer-aided detection software, which is essentially using AI with some front-end coding that has been invented and was available already at the time for TB detection, early TB detection. As the Honorable Minister of South Africa mentioned, for TB and like other airborne infectious diseases, symptom is not the only and should be used as the only early detection sign. Often, infectious diseases like TB and COVID are transmitted among asymptomatic individuals. So it's really critical to invest in X-ray that can capture those asymptomatic individuals and then put them on care. A lot of burden of introducing X-ray, at least in TB in the early year, has because of the insufficient trained human readers or the inability to consolidate the inner and intra-reader variability. And those barriers has been addressed by the introduction of AI technology. From the early introduction, we have seen that AI technology has been used to prioritize the workflow of human readers, alert radiologists to potentially abnormal images, and providing report assistance, quality controls, and also perform pre-reading assistance. In the past less than 1 decade following the emergence of the first AI technology for TB, a lot has been done and achieved in improving the accuracy of detecting TB using AI from X-ray. So much that the very first WHO recommendation on the use of AI was actually for TB. In March last year, WHO has recommended the use of AI for TB screening to replace human to screen and triage TB in individual 15 and above. This is a watershed moment, as no such recommendation has ever been made by WHO on AI for any other diseases, but TB is leading the way. Next slide. Now, next slide. So also we have seen in the past less than 1 decade, before and after the WHO recommendation, the industry for TB AI has completely mushroomed, where in the early 2010s, there were only 1 product. But as far as last year, in the most recent landscape, market landscape analysis that Stop TB and FINE has conducted, at least 28 AI developers are existing active in the space of TB, and 12 TB specific AI products are already available on this market. Next slide, please. On the hardware side, so we talk about the software side on AI. There are also some exciting development, particularly with the miniaturization of digital X-ray as shown on the slides, which give us some of the X-ray that you can hold by hand, as you can see here, which give a much lower radiation and still give us clear images. With combined AI and the miniaturization of digital X-ray, we're presented with the opportunity to go very decentralized to the peripheral setting, to the clear, close to point of care setting, and bringing radiology assessment to patient home, to patient doorstep, instead of having them coming to the facility. It's also interesting to know that this type of the ultra portable X-ray showing in the slides, they were actually initially designed not for TB, but for senior care in Japan, where healthcare provider go door to door to visit the patient who are not able to go to the facility. But an application in TB and communicable diseases has been discovered that such technology can be used and for the first time extending radiologist assessment to the community. And since then, there has been a multiple type of product that are available that are also as portable as these 3 that are shown on the screen. Next slide, please. Perhaps after seeing the great potential of combining ultra-portable X-ray with AI and following the recommendation of WHO, the Stop TB and USA projects on introducing new tools project, thanks to US's funding, when we were looking at rolling out a package of the latest innovation in diagnostic and treatment, to strengthen TB care in high TB burden country, we have included ultra-portable X-ray and AI in this package. And under this new tools project, a total of 63 ultra-portable X-ray, along with AI, has been supplied to 7 countries to assist with TB detection in some of the most remote setting. And this is, we're proud to say, the very first scale-up project ever to roll out this technology in high burden countries. Next slides, please. Next, so in the next few slides, we will look at the spillover effect of AI's application and ultra-portable X-ray going beyond TB. Perhaps one of the best example is looking at COVID, as it just happened in the past 2 years. When we first introduced ultra-portable X-ray and piloted ultra-portable X-ray and AI, it just happened to be on the cusp of the COVID outburst. And as a result, what we're seeing firsthand is that some of the pilot projects literally took their ultra portable X-ray. Because they are so portable, initially they were meant for community-based screening in mining community, in urban slum. They were able to quickly reprogram them and reposition them as a COVID screening center, as shown on the slides here. A grantee in Pakistan has utilized the one ultra portable X-ray with AI to screen people for COVID that are going through a COVID screening center in the capital, one of the tertiary hospital. As a result, a lot of asymptomatic COVID patients were flagged for screening, and they would have been missed if this technology was not available. Next slide, please. So AI can also help to fight against COVID, in addition to applied in the community-based screening to reduce time to diagnosis. There's a lot of publications are available to show that AI has been used to track the spread of virus and to identify patients with potentially high mortality risk and therefore needing more intensive care and need to be hospitalized. Next slides, please. And so there are also other areas where we see a spillover effect. AI can be used to enhance healthcare. As AI can perform image reading by exploiting deep learning technology. So it's able to not only extract visual information, but also to quantify those information, such as acoustic signal. So we've seen also during COVID time, there were a lot of applications, like Amazon has put out AI application that can detect COVID from cough sound. So those cough sound can actually be transformed as an imaging format, and the same AI technology that we've been used as other X-ray imaging can apply on cough sound to detect COVID. And we know there's some ongoing work that StopTB is also involved in using the same technology to detect TB and other pulmonary diseases. Another example, which really showed the cross-industry application of AI, an imaging AI tool were developed to detect the defect pastry from video surveillance, but where since application has been transformed to detect cancer cell. Next slide, please. So how can AI help in task shift for health? By training artificial intelligence model on more diverse imaging data set, and we can augment decision making and overcome the knowledge gap and promote the greater health equity and outcome by using AI to help optimize radiology workflow, and then allowing a country where there's insufficient radiologists still be able to benefit from radiologists, and providing healthcare worker faster tools to detect and diagnose pulmonary diseases, and providing cost-effective solution that contribute to the greater saving of programmatic costs. Next slide, please. And this will be the last slide. So as a way of ending this presentation, here what we like to call for action, what we like to recommend after we have seen that AI imaging is a fast growing areas and fast growing technology, and it has been proven to be beneficial in TB and other airborne diseases, and further scale up should be supported for future pandemic preparedness as well. As the three distinct asks we would like to call for as a next step is first to definitely increase investment on AI imaging for healthcare. That is not just R&D, but also investing in the infrastructure that is required to enable AI imaging for TB and other pulmonary diseases, as well as training and building capacity of healthcare worker on this type of technology. And finally, a greater advocacy to key stakeholders to continue promote the use of AI in healthcare. Next slide. So that concludes my presentation, and thank you so much for your time, and I stand for question. Over to you, Chair.
Thank you, Zhisheng. This is really great to see the advances being made and how these have been already deployed. We now have an opportunity to address any questions or comments from webinar participants. As a reminder, several of you have been posting questions in the chat box, and several of these, if not most, have already been answered. There was a question for Shamron about the yield of stool testing for children with potential tuberculosis. If unable to answer that now, we could certainly try to address it later, but let me give Shamron an opportunity. I would assume that Bill might have also more to say on this, but just going back to that particular question about the yield of stool-based testing to diagnose tuberculosis in children who evidently cannot produce good sputum specimens.
Thank you so much, Professor Ken. I think this is really a good question. Actually, the discussion around taking stool as the sample for finding TB among children is also one of the discussion here, and we have just started the doing this investigation. So hopefully there will be some learning from that example, and that is correct. The learning from other project that currently implemented by Institute of Pasteur of Cambodia, they also mentioned about this as well. So that's why, with support from USAID, we have tested this modality in a few hospitals, and we hope we will have some data to prove that. Thank you.
Thank you. Bill, do you want to follow up maybe?
Yeah, I mean, there have been a number of studies supported across the world on the use of stool in Gexpert, and I think the data are a little mixed. There's obviously a role where it can identify some cases, especially in high prevalence settings or with high pretest probability, but there's a need for more more detailed studies to identify exactly the role and at what point in the diagnostic pathway stool for TB should be used. It clearly has some role to play, and in some cases it's been an important adjunct in identifying patients with negative tests from sputum.
Great, thank you. I see a couple of questions for Zhisheng. First one is interesting to know we have less invasive means for chest x-ray and TB diagnosis. Can the same technology be used for other lung diseases? I think the short answer is yes, but I'll let you expand on that. And then there's another follow-up, would like someone asking, how long is the typical duration of artificial intelligence training on diagnosis of TB through x-ray imaging? An opportunity for you to clarify that.
Thank you, Chair, and thank you for the question. Those are really good questions. And regarding Philippe's, your question on whether there's also less invasive means for non-TB and other pulmonary diseases, the answer is yes. I didn't have time to go over, but indeed, when I was showing those product landscape analysis, almost all the tools that are available now for TB now have different modules for other pulmonary diseases, such as lung cancer, viral pneumonia, if it's COVID or not, and other pulmonary diseases depend on the product. So the short answer to that is definitely yes. Whether or not that those product has achieved regulatory approval, this will depend. And then we're still, but it's an industry that is growing very fast. We can very well see a very comprehensive AI care available for all pulmonary diseases in the near futures. And on the question from Austin about the duration of training artificial intelligence. Yes, that's also a very good question. The evolution for TB started from early 2010 until 2021 for the WHO recommendation. It took us 10 years to get a really good product that can replace human for certain use case, although not for diagnosis. What is very interesting to see, though, is for COVID as a comparison. For the first COVID product to be available, AI product to be available, it didn't take 10 years. Instead, it only just took a few months. And it does also speak to the investment of TB, because essentially a lot of those COVID products were built on to the TB product and were retrained on just a few number of new COVID X-ray imaging. And that does speak to the underlying investment on TB, how it can be transformed to other diseases. If let's say in the future is something else, and we can also utilize the TB model and quickly reprogram them for the other type of pulmonary diseases. And on the accuracy, the products are able to be independently diagnosing TB. They can definitely not, as per WHO recommendation, be independently triage and screen TB for follow-on confirmation testing, but it has not yet achieved as a accurate diagnostic tools for TB, partly because of the limitation of X-ray, not so much because of the AI itself, as X-ray is only a two-dimension manifestation of the long field. And I see, Elaine, you have a question on acceptability of AI among radiologists. Yes, it's been threatened to be replaced. That's also a very good question. And I think oftentimes people, when they hear about TB, they fear about being replaced. And it's important to know, as I also mentioned earlier, that AI has not been able to completely do TB diagnosis, for example, because it's limited with the underlying technology. And also we have not achieved the level of general AI, which is something that human is able to achieve. We're only focusing on narrow use case. And so narrow that is for TB is only screen and triage. And I don't think if ever AI is able to improve, we're really talking about replacing radiologists, but rather enhancing. We're seeing the application of enhancing humans radiologists' work to help them focusing on more urgent cases, help prioritizing their workflow. For example, in TB massive active case finding or COVID active case finding, the number of throughput is just simply not manageable for human, where this is where AI would definitely add a lot of benefit instead of to threaten the work of radiologists. Yeah, I think that's about it. Over to you, Chair.
Thank you very much for your excellent and comprehensive responses to the questions that have been posted. I see that Falguni has a comment to share. If you could keep it short, I would appreciate it. Thank you.
Thank you, Chair. Actually, I want to conclude here. The numerous steps along the TB side of care pose challenges, but also opportunity to engage patients to ensure service meet their needs. TB programs can improve the quality of latent TB service by implementing regular and standardized evaluation of TB of care with implementation of intervention to resolve gaps in care. This will lead to improvements in identification, diagnosis, treatment, and retention in care of person with latent TB. Ultimately, this will reduce the number of persons developing activities TB disease, thereby bringing an end to TB globally. The burden of inaction is great. Aim to reduce TB death by 95% and incidence by 90% within the next 15 years. Demand the rapid implementation of strong coordinated quality program to achieve these ambitious improvements in population health. Lesson learned from the success and failure of HIV program in addressing quality offer a starting point from which TB program must live to make progress towards elimination. Donor and country funding for scaling up novel diagnostics is essential. However, there needs to be greater investment focused on improving the quality of TB care that accompanies funding to achieve maximal impact of novel diagnosis such as expert. This invest should include specific funds for co-interventions such as training process, redesigning, performance feedback and analysis infrastructure relevant to local context and barriers to high quality service delivery. Proper implementation support are essential for new diagnostics to fully realize their promising potential. Implementation science-based approach can facilitate a systematic assessment of key barriers, enablers, and guide selection of most appropriate and feasible implementation support for given context. And the main thing I want to conclude here about COVID-19 also, progress towards SDG and TB and United Nations high-level TB meeting targets is lagging. For example, while the target for TB preventive therapy is 30 million by 2022, only 6.3 people have been treated during 2018 and 2019, while the target for funding TB care and prevention is 13 billion annually. Only 6.5 billion were raised during 2020. As predict, the COVID-19 pandemic is making things worse. In September, several civil society organizations working on TB released the result of large survey done to document the impact of pandemic on TB care, research and funding around the world. Policy and program officer reported significant drop in TB notification. Over 70% of healthcare workers and advocates reported a decrease in the number of people coming to health facility for TB testing. In terms
Falguni, thank you. I appreciate that. I'm just afraid that we may not have an opportunity to entertain other questions, but what you're saying is very clear to us that we've fallen short and we're lagging behind and there's more to be done. And that's precisely the purpose of the AIDP, is to use it as a platform to accelerate progress against tuberculosis as we accelerate progress against other airborne pathogens. I share with you the passion as well as the frustration with the lagging behind in tuberculosis. But thank you. I just wanted to see that I did see that Sahu had a comment about COVID has taught us about the high yield of high positivity of testing. Do you want to expand on that, Sahu?
Thank you, Ken. It was related to a question and a discussion point on the low yield. I think during the COVID pandemic, we saw how low yield was taken as a good thing. That means the testing coverage is good. People are being tested. So you will find a lot of people negative. Conversely, high yield was taken as a bad thing, that the COVID testing is not happening enough. I think in TB, it is time now for us to rethink what we have been doing related to yield. As TB ends, we should have more and more people with symptoms, without symptoms tested, and less people getting confirmed for TB. I think tests have to be designed in that way, and testing strategies have to be designed in that way. So that was my point. Thank you.
And Ken, just to add to that, I mean, the more we push for an active case finding strategy, right, the more dependent we are on less expensive tests, because we want to see a positivity rate that's relatively low, right? We're going to see that, but that's the only approach to doing that kind of active case finding, as Sahu just mentioned. And it's a balance. We have to find the right strategies to be cost effective, but to really drive the agenda of finding the missing cases.
I agree. I mean, I think the Minister of South Africa mentioned earlier the recent TB prevalence survey there, and one of the key findings there is a number of people who respond negatively to the symptom screen. So we're going to need to figure out a way to identify subpopulations with high background levels and screen them before they show up any symptoms, because in the absence of symptoms, they're not going to be seeking care, and yet they're probably going to be transmitting in the community. So you're all absolutely right. And this is where actually the non-invasive chest radiograph linked with AI would be a first useful step. And parenthetically, I will acknowledge here that we've seen a reversal. There was a time when the TB community had wanted to do nothing with chest radiographs because of the number of garbage diagnoses that were provided by people who never did a bacteriologic confirmation, and they just did TB treatment on the basis of abnormal x-rays. Now we've seen a change, a new approach with the artificial intelligence, the ultra-portable x-rays, and the linkage to bacteriologic confirmation really enables us to do justice to those who need to be placed on treatment. I don't know if Xingzhen or others have any other parting comments. I know that we're 3 minutes away from closing time, but I'll give you that opportunity to close this out.
Yeah, so I just wanted to 100% agree, because X-ray is not new, and it's not the first time that X-rays ever been used in TB. But what we're seeing is incremental innovation that addresses the shortcoming of certain aspect of a technology, can exponentially increase its application of an existing technology. And I think that speaks to also looking into other innovations that are already existing, and then looking into how can we improve that to help combating TB and other airborne diseases. Could be as important as reinventing something that's not existing, looking at new innovation. Yeah.
Thank you so much. So let us wrap this up first by thanking each and every single one of the presenters for an outstanding set of presentations. I will remind those on this webinar that tomorrow we have day 2 of the webinar with a session 3 that will focus on how can systems and platforms for TB care and referrals be optimized and applied to other respiratory diseases. And then a concluding 4th session about surveillance and response information for action by facilities and communities. Join us at the same time tomorrow, and I hope to see the same level of enthusiasm and engagement with the Q&As. As mentioned by Tara Ornstein and others before, this session had been both live streamed, is being recorded, and a summary will be forthcoming afterwards. I'm reminded by Dr. Amy Bloom that there's a talk tomorrow on infection prevention control, which has generated some earlier questions, and we hope that all can attend and really use this as an opportunity to further expand on that. With that, and we're concluding, and I want to turn it over to Sahu for any remarks from Stop TB Partnership. And I'm grateful to all of you because you've made my job easy today. Sahu, any comments?
Thank you, Ken, for moderating today's sessions. As you said, we will start tomorrow at the same time. Those of you who have registered for day 1 as well as day 2 are fine. Those of you who want to register for day 2, please go ahead. And thanks to everybody who supported this webinar in terms of logistics, also the translators and people who were behind the scenes. So see you all tomorrow at the same time.
See you tomorrow. Thank you and take
Thank
care.
you.
I'll be signing out.
Thank you. Bye bye.
9:30. Bye.
Thank you. Great chat.